Hello everyone, my name is Daniel. I am a final year medical student and I am currently a USMLE Step 3 aspirant. And in this video, we're going to talk about the high yield general pathology. So, this video lecture will cover all the concept of general pathology, and after going through this video, you can enter into the systems and systematic pathology, right? So, keep in mind that this video lecture will highlight the basic stuff of the pathology, general pathology, and we cannot go into the detail of every stuff, but I'll go into the detail where needed. So let me be very honest with you that this video lecture will end up making you very I can say very confident in the basic pathology concept. So let's start. So the first okay, so if you see episodes if you see this episode thing here, please ignore it. So by episode I simply mean that this is the first topic we're gonna discuss. So the first thing I'm gonna discuss with you is the cell adaptation and injury, and after that I'll jump into the cell death and necrosis, and then the third thing I'm gonna discuss with you will be inflammation and healing, and here I'll discuss the chronic and the acute inflammation, and then I'm gonna discuss about some hemodynamics, neoplasia, and amyloidosis, and specials, cellular inclusions, and all those things. So let's start with our first topic, which is cellular adaptation. So before we go into the pathology like cell injury and necrosis and apoptosis, the body actually tries to stress the body adapt the stress first, and I have highlighted this thing in my previous lecture as well. So you should think of it in this way, that when a cell faces stress, it has two options: either it adapts or it gets injured or and dies. So adaptation is basically the survival strategy of the cell. And remember, the major adaptation, I want you to keep one simple mnemonic in mind, that HAMDA, hamda. From H we mean hypertrophy, from A we mean atrophy, from M we mean metaplasia, and from by D we mean dysplasia, and from A we mean adaptation. So just keep in mind these basic stuff, and now I'm gonna start with this one, which is the hypertrophy. So yeah, just give me a minute. Okay, yeah. So hypertrophy versus hyperplasia. Students often confuse these two, but the difference is actually very simple. Hypertrophy means increase in cell size, not the number of cells, just the size of each individual cell become bigger. This usually happens in a cell that cannot divide. The classic example is cardiac muscle. When someone has chronic hypertension, the heart has to pump against the high resistance. So what actually happens is that the cardiac muscle cells cannot multiply, but they increase their size to generate more force, and this leads to cardiac hypertrophy. So remember, hypertrophy means bigger cells. Now, if I talk about the hyperplasia, so it is different. By hyperplasia, we increase the number of cells. So instead of cells getting bigger, the body so instead of cells getting bigger, the body produces more cell, and this happens in tissue that are capable of cell division. Classic example is the endometrial hyperplasia. When estrogen level increases, the endometrium responds by proliferating and leading to increased number of cells. So remember, the simple discussion is a distinction between the hypertrophy and hyperplasia is that hypertrophy is increase in cell size, whereas hyperplasia is increase in cell number. Now, if I jump on to the next topic, which is atrophy, so it's actually the opposite of the situation. Instead of growing, the cells actually shrink. This is called atrophy. Atrophy means decrease in cell size and sometimes cell number. Cells become smaller because they reduce their metabolic activity. Inside the cell, there are two important mechanisms that cause this. So the first mechanism that is responsible for the atrophy is the ubiquitin-proteasome pathway, and the second one is autophagy. So ubiquitin-proteasome pathway, I would simply say that in ubiquitin-proteasome pathway there is a tag on the cell by a protein called as ubiquitin, and when protein ubiquitin is tagged on the cell or cell organelles, more specifically cell organelles, so there is another organelle inside your cell which is called as proteasome. So proteasome sends the cells or cell organelles that are tagged with the protein ubiquitin, and the proteasome degrades those organelles that are tagged with ubiquitin, and this is how this ubiquitin proteasome pathway works. Now there is another mechanism which is called as autophagy, and autophagy simply means that the cell digests its own organelles to survive. That's how the autophagy works, right? So in autophagy there is something called as autolysosome formation, and that leads to the cellular destruction. So that autophagolysosome consists of lysosomal enzyme in it, and those and this autophagolysosome actually engulfs the organelles that are supposed to be engulfed, or that are supposed to be die, and this autophagolysosome engulf those organelles and they are dead, right? So this is how this autophagy works. Now think of it like the cell is saying, I don't have enough resources, so I'll reduce my size and recycle my components. So this is how the autophagy works. Now the common example of, this is how the atrophy works. So the common cause of atrophy includes disuse, for example, muscle wasting when a limb is immobilized, degeneration when nerve supply is lost, ischemia when blood supply decreases. So the key idea is atrophy is actually cell shrinkage due to reduced demands or reduced supply. Now so this is what atrophy is. Now if I start the next or jump onto the next topic, then it is metaplasia. Keep in mind that this is a one-shot video. I have to be fast and I have to be as precise as I can. So the next topic is metaplasia. Now things get a little more interesting here, because metaplasia means one mature cell type is replaced by another mature cell type. This change is usually a response to chronic irritation or stress. But the more important thing is metaplasia is reversible. The body is actually trying to protect itself by replacing a sensitive cell type with a more resistant one. So the classic example everyone should remember is Barrett's esophagus. So normally the esophagus is lined by a stratified squamous epithelium, but when someone has chronic acid reflux, this squamous epithelium is repeatedly exposed to acid. So the body replaces its columnar epithelium with more resistant to acidic condition. So this change, squamous epithelium to columnar epithelium, is simply called as metaplasia. So however, even though it is protective, long-standing metaplasia can increase cancer risk. So that's why there are people who are chronic GERD patient and they end up having esophageal cancer. So now if I talk about the next thing, this is dysplasia. So dysplasia is simply means that disordered cellular growth. So here the cells are showing abnormal architecture and atypical feature. Some of the macroscopic feature includes loss of cellular orientation, irregular arrangement of the cells, nuclear atypia, increased nuclear size, and sometimes increased mitotic figures. So this is something that these are the small details that I think you should keep in mind, but if you cannot, then it's fine. With time you will memorize the stuff, but keep these things in mind, right? So let me repeat it again. So there are some macroscopic feature in dysplasia that you should pay attention on, that there is loss of cellular orientation, there is irregular arrangement of cells, there might be nuclear atypia, there might be increased nuclear size, and sometimes there might be increased mitotic figures as well. So keep in mind that dysplasia is considered a pre-malignant stage, meaning it has a potential to grow into the cancer. So however, the important thing is this dysplasia can still be reversible if the stressor is removed early. Like for example, cervical dysplasia caused by HPV infection can sometimes regress if the HPV infection is detected earlier by HPV testing. So that's why HPV screening and testing is really important, and Pakistan has been recently introduced to this kind of stuff. So but if the stress persists, dysplasia can eventually progress to a carcinoma. Keep this in mind. So a quick recap would be HAMDA, hypertrophy, increase in cell size; atrophy, decrease in cell size; metaplasia, increase in one cell type is replaced by another. Dysplasia simply means disordered pre-malignant growth, and adaptation means the overall survival response, which we have been discussing here. So remember, cell first adapt. If the adaptation fails, injury begins, and that is where the next major topic starts, which is the reversible versus irreversible injury. All right. So now, what actually happened that if you understand now, if you understand the cellular adaptation, the next question would be that what happens when the stress becomes too severe. So at that point, the cell moves from adaptation to injury. But even in injury, there are two stages: so the reversible cell injury and the irreversible cell injury. And the transition between them is something very important in pathology. So first of all, let's discuss what is the point of no return. Then I'll talk about this basic stuff. So the point of no return, which is you can say that it's a critical moment where the cell can no longer recover even if the original stress is removed. So once the cell crosses this point, cell death become inevitable, and I have repeatedly discussed this thing in my previous lectures that once you cross the point of no return, the cell death becomes inevitable. So what actually happens at the point of no return? Let me tell you. So there are the two major catastrophic events occur inside a cell. First of all, calcium influx. Normally, intracellular calcium levels are very tightly regulated, right? But during severe injury, the plasma membrane and mitochondria becomes damaged, allowing calcium to flood into the cytoplasm. High intracellular calcium activates destructive enzymes like the phospholipases, proteases, and the nucleases and ATPases. By activating phospholipases, you simply destroy the cell membrane, and by activating proteases, you are degrading the cytoskeleton, and by activating endonucleases, you are simply fragmenting the DNA, and by activating ATPases, you are worsening the ATP depletion. So calcium essentially turns on the cell's self-destruction machinery. So this is the first thing that actually happens, which is a calcium influx. Now, the second thing that actually happens at this point of no return is the membrane damage. So the second critical event is a membrane damage, is the severe membrane damage injury, which is very critical thing to consider here because plasma membrane events, because there are a few membranes that are actually damaged. So first one is plasma membrane, the second one you should worry about is the mitochondrial, and the third one you should be worried about and you should be fanatical about is the lysosomal membrane. So when the plasma membrane damage, of course the cell content will leak out. When the mitochondrial membrane damage, there will be no ATP production, of course. But when the lysosomal membrane damage, digestive enzymes are released, and it simply causes the auto-digestion of the cell, and these lysosomal enzymes simply digest the cell. So once this level of damage occurs, the cell cannot repair itself anymore. So that is why I always call it the point of no return. This is not a textbook word, but I use this word, the point of no return, to explain the thing to my students. Now, ischemia timeline. So first of all, let's understand this with a clinical example. So, ischemia means loss of blood supply, which leads to oxygen and nutrition deprivation. So, the timeline of damage is actually very important in exams and clinical medicine, of course, because within less than 2 minutes, cells lose their functional ability. For example, if I talk about myocardial ischemia, or like heart attack, in other words, in a layman's term, so in myocardial ischemia, the heart muscle stops contracting within 2 minutes. But at this stage, the damage is still reversible. If blood flow is restored quickly, the cell can recover. So this is the importance of the timing. Now, but if you delay this if after about 20 to 40 minutes of severe ischemia, injury become irreversible because at this point the cell death begins. However, some tissues are much more sensitive, like for suppose the neuron can die within 3 to 5 minutes of ischemia. This is why brain ischemia during cardiac arrest causes permanent damage so quickly. So this is what about the ischemia timeline. Just keep in mind that when there is ischemia to the organ, you have to restore the blood supply as soon as possible. But if you are delaying it, you are simply causing the death of the cell. Remember, in ischemia, time is the cell. The more time you are losing, the more cells you are losing, and the more muscle you are losing, and the more function you are losing. So now let's talk about the reversible versus irreversible injury. I've again talked about this in my previous lectures as well, but here I'll go into this topic, and I'm sorry, I'll be super fast here. So, in reversible injury, the main problem is the ATP depletion. Because ATP drops, the sodium potassium pump fails, and when this pump is not working, sodium accumulates inside a cell. Water follows the sodium, the cell begins to swell, and this swelling is called as hydrophobic change inside the cell. So, the hallmark of the reversible injury is the cellular swelling. Another important reversible change is the fatty change, especially in the liver. So this happens because the impaired metabolism that leads to lipid accumulation inside the hepatocytes. At the microscopic level, we also see ribosome detached from the rough endoplasmic reticulum, protein synthesis decreases, and all of these changes are still reversible if the stress is removed. Now, if I talk about the irreversible injury, so let's suppose and in the irreversible injury, simply the damage becomes severe and permanent. Now, the two key mechanisms that dominate here is the severe membrane damage and the mitochondrial dysfunction. So, mitochondria undergoes something called a mitochondrial permeability transition, which completely shuts down the ATP production. Meanwhile, the membrane damage leads to plasma membrane rupture, lysosomal enzyme leakage, and autodigestion of the cell. So it simply means that in the irreversible injury, cell is in the point of no return, right? So at this stage, again, the cell death is unavoidable, it is unavoidable, and that's it. Now, I want to discuss few nuclear changes that again I have discussed in my previous lecture, but I'll discuss them here again. So pycnosis, that is a hallmark. There are a few nuclear changes that are hallmark of the irreversible cellular injury. So first of all, the pycnosis. The nucleus become in the pycnosis, the nucleus becomes small, dark, and shrunken due to chromatin condensation. Right, this is the right word. So now for karyorrhexis, the nucleus breaks into the fragments, and the other thing which is karyolysis, the nuclear material dissolves and fades away. So pycnosis means shrinkage, karyorrhexis means fragmentation, and karyolysis means you are simply fading away, like the memories fades away from someone's heart. Memories are in the heart? No, they're in the brain. Anyways, so the sequence is pycnosis, karyorrhexis, and finally karyolysis. So now there are a few ultrastructure changes that I want to discuss with you, and if you look under the electron microscope, the difference becomes even more clearer. So for the reversible injury, we see membrane blabbing, we see loss of microvilli, swelling of endoplasmic reticulum. These changes indicate that the cell is injured but is still alive, because again, it's reversible cellular injury. Once the stress is removed, there is a chance the cell can recover. Now, if I talk about the ultrastructure changes of the irreversible injury, so it simply means that we see more severe findings like lost large membrane defects, ruptured plasma membrane, and amorphous dense deposits in the mitochondria. So these mitochondrial density are a classic sign that the cell is beyond recovery, right? So a quick clinical takeaway would be for you that remember the sequence. Stress leads to adaptation. Adaptation, if the cell is not adapting, then it will lead to reversible cell injury. And after reversible cell injury, cell enters into the point of no return, which is actually the irreversible cell injury, and that leads to cell death. Excuse me. So this cell death will eventually manifest as either now necrosis or apoptosis. So this would be our next topic. So you can see how systematically we are going here. So first of all, let's talk about the necrosis. So what is important for you is to remember the different types of necrosis. This is very important for you, but I'll give you a brief overview of necrosis as well. I think that I've explained the necrosis in my previous lectures as well. Now, so let's suppose we have crossed the point of no return and the cell has entered into the irreversible injury. So, and the most common outcome of the irreversible cell injury is something called as necrosis. Necrosis is basically uncontrolled cell death that is caused by severe injury, and unlike apoptosis, necrosis leads to inflammation because the cell membrane ruptures here and intercellular components spills out. So the pathology classifies necrosis into the six major classification. and I'm giving a mnemonic of these things, CLC, FFG. Is you can say it is very rhythmic. CLC, FFG, CLC, FFG. It is very rhythmic. I would be really happy to know that if you remember my voice, CLC, FFG in the examination, and it would pay off my effort. So let's talk about the cognitive necrosis. This is the most common type of necrosis in the body. So the typical cause is the ischemic infarction, meaning loss of blood supply to the tissue. But there is one very famous exception for the cognitive necrosis, which is that the brain. So brain let's suppose almost all the organ undergo cognitive necrosis during ischemia. So cognitive necrosis, again, I'm explaining it. That is something related to the infarction. That is related to the loss of blood supply, ischemia, right? So almost all organs undergo cognitive necrosis during ischemia except the brain. The brain instead undergoes liquefactive necrosis, and I'll now let me discuss you with some microscopic feature of the necrosis of the different type of necrosis with you. So first of all, now the key microscopic finding of the cognitive necrosis would be I can say that it is very interesting because even though the cells are dead, but the basic structure or architecture of these cells remain preserved for a few days. So under a microscope, you can still see the outline of the cell, but the cells themselves are non-functional, and pathologists say this thing as ghost cell outline. So why does this happen? Because protein becomes denatured, including the enzyme that normally digest the cell. So since the enzymes are inactivated, the autodigestion is slowed, and the structure temporarily remain intact. So the classic example includes the myocardial infarction, kidney infarction, and splenic infarction. So remember, cognitive necrosis leads to ischemia plus preserved. Cognitive necrosis is equal to ischemia plus preserved architecture. This is what cognitive necrosis is. Now, if I talk about the liquefactive necrosis, so liquefactive necrosis is almost complete opposite of the cognitive necrosis. So here the tissue is completely destroyed. The cell architecture is completely destroyed. Instead of maintaining the structure, the tissue actually turns out into a viscous liquid mass, and this happens because enzymes digestion dominates here. So neutrophils, because remember, liquefactive necrosis mostly occur in the tissues that are literally high in the neutrophil, or they are in a state in which the neutrophil count is very high. So actually this happens in the bacterial infection when the neutrophil count is raised, and this also happens in the brain because brains got a lot of neutrophil, right? So neutrophil actually releases powerful hydrolytic substances or hydrolytic enzymes which rapidly digest that tissue, and this is what gives a liquefactive appearance or liquid viscous mass-like appearance on the microscope. So let's talk about if I'm talking about the brain infarction here. So again, brain is unique in ischemia in the because if there is ischemia in the brain, it will lead to liquefactive necrosis rather than the cognitive necrosis. That's why brain is unique in ischemia. Brain is very unique organ. So, and the second thing I've discussed again, and I'll explain to you again, that is bacterial infection, because in bacterial infection there is abscess formation, and I've told you in the abscess formation there is a lot of neutrophil, and those neutrophil will release digestive enzyme, and this will lead to the ischemia. This will lead to some liquid viscous mass, right? So this is what liquefactive necrosis is. So that's it for the liquefactive necrosis. Just keep in mind that liquefactive necrosis is something enzymatic digestion plus pus formation, right? So that liquefactive mass is actually this viscous mass is actually the pus, if I'm talking about the bacterial infection. So now our next topic would be the caseous necrosis. So caseous necrosis has a very distinctive appearance. So the word caseous actually described from a Latin word which simply means cheese, right? So cheese or cheese-like material. So, and this caseous necrosis is exactly what it looks like. Is the soft, white, cheese-like material. So this type of necrosis is classified as is classically associated with the tuberculosis, and it can also occur with the certain fungal infection, And microscopically, the tissue structure is completely destroyed and the necrotic area appears as amorphous granular debris. But the most important structure of the feature is the granuloma. So granuloma are some organized, and you can say that collective collections of immune cells surrounding the necrotic center. So the typical structure look like the immune cells forming a ring around the central caseous necrosis. So this would be like, so what is a caseous necrosis is? So in caseous necrosis, you're gonna see the debris, you're gonna see the junk, everything inside the center of this tissue, and this center is surrounded by the neutrophils, or sorry, the all other immune cells. I'm not going into the detail of the type of immune cells, but they are mostly T cells or macrophages. Let me be more correct. So this junk is surrounded by the macrophages, and this is called the caseous necrosis. Actually, this is called a granuloma. This is actually called a granuloma, to be more correct. So yeah, so caseous necrosis equals to TB plus granuloma plus cheese-like appearance. So now let's talk about the other topic, the thing that is the fat necrosis. So fat necrosis occurs specifically in the fat tissues. There are two main causes. The first is enzymatic fat necrosis, usually seen in acute pancreatitis, and okay, so yeah, so the first is enzymatic fat necrosis that is usually seen in the acute pancreatitis, and the second cause is traumatic fat necrosis that is usually seen in the breast tissues. So yeah, let me get into the detail of the acute pancreatitis. So when pancreatic enzymes leak out, lipases, which is actually an enzyme, which is actually a pancreatic enzyme. So lipases start breaking down the fat cells. They release fatty acid, then combine with the calcium ions in the tissue, and this is something called a saponification, and this forms the calcium salts. And these calcium salts appear chalky white during surgery or pathology examination. Now the second thing is traumatic fat necrosis. So trauma damages the adipose tissue, leading to similar fat breakdown and the inflammation, and the same thing. So saponification actually simply happens in the fat, in the breast trauma, or if you're talking about the acute pancreatitis. So in both cases, there is actually saponification. So fat necrosis is simply about the saponification. Now, if I talk about the gangrenous necrosis, so gangrene is actually a more of clinical term rather than a purely microscopic classification. So it usually occurs when severe ischemia affect the large area of tissue, particularly in the lower limbs or gastrointestinal tract. So gangrene can be divided into two main types. So I think that you should listen to this very carefully. And this is something I used to forget when I was step 1 candidate. So the first one is dry gangrene, and the second one is the wet gangrene. Dry gangrene occurs when the tissue undergoes ischemia, coagulated necrosis, and without ischemic coagulated necrosis, be more correct, without infection. Dry gangrenous necrosis is something without infection. Without infection, the tissue becomes dry, dark, and shriveled. So essentially, dry gangrene is basically coagulated necrosis because it is occurring due to some ischemia, right? Now, if I talk about the wet gangrenous necrosis, so wet gangrene occurs when bacterial infection superimpose the ischemic tissue. The bacteria and neutrophils release the enzymes that digest the tissue, and this converts this tissue into the liquefactive necrosis. Now, wet gangrene is actually the coagulated necrosis plus superimposed infection, and that causes liquefaction. Right? So I think that I'm clear at this moment, and I'm super clear at this moment. Now, thank you guys, because of you, I'm also revising my stuff. Now let's talk about the fibrinoid necrosis. So the last type is fibrinoid necrosis, and this is one is a little different from others. Now, it mainly occurs in the blood vessels. It is usually associated with the immune-mediated vascular injury. So, classic diseases includes the malignant hypertension, vasculitis, systemic lupus erythematosus, and in these conditions, immune complexes and plasma protein leak out into the vessel wall. These protein deposit into the within the wall and stain bright pink on H&E microscopy, and this gives the vessel a fibrin-like appearance, which is why it is called fibrinoid necrosis. So, and remember, in fibrinoid necrosis, immune complexes are damaging the vessel walls. So it's basically a more stuff of the vasculitis. Keep in mind, you are having a blood vessel, and in that blood vessel, the immune complexes are depositing, and when the plasma immune complexes deposits in the vessel wall, this actually cause the wall, the blood vessel, the blood vascular wall to stain bright pink on H&E microscopy, and this is what actually called the fibrinoid necrosis. Whenever you're talking about the vascular necrosis, keep in mind that you are talking about the fibrinoid necrosis. This is the best go point I can give to you, because this will help you a lot in the USMLEs, a lot. Now, a quick rapid revision would be that coagulative necrosis is actually the ischemia and architecture is preserved. Liquefied necrosis is brain infarct, abscess, pus. Caseous necrosis is simply, you can say, TB, cheese-like granulomas. Fat necrosis is pancreatitis, saponification, and fibrinoid necrosis is actually the immune complex damage in the vessels, and gangrenous necrosis is severe ischemia, and that might be dry if it is not without infection, and it might be wet if it is with infection. So now we've understood how the cell died through the necrosis, but interestingly, the body also has a programmed and controlled way of killing the cells, a much cleaner and a regulated process, and that process is called apoptosis. Now, which is exactly we are going to discuss next, of course, and now, of course, we have seen how cells die massively through necrosis. It is a very messy way, of course, and it's spilling their guts and trickling inflammation, but the body also has a much cleaner and smarter way to die, a process which is called as apoptosis. Now, but the body, you can say that necrosis, I would simply say, the body will say, for the necrosis, the body convinced that it is murder, but for the apoptosis, the body is like it's a suicide. Yes, apoptosis is a programmed cell death and a planned cellular self-destruction that's actually beneficial to your body. So, the two main pathways of the apoptosis are the intrinsic and the extrinsic pathway. Alright, so let's go into the slight detail of the intrinsic pathway. It is triggered when the cell detects internal stresses like DNA damage, like decreased hormonal stimulation. The key event here is the mitochondria releasing cytochrome C into the cytoplasm. Cytochrome C then activates a cascade of enzymes which are called as caspases, right? And they actually execute the cell death program. Now, this apoptosis is tightly regulated by two sort of proteins, which are the BAX and the BAC protein, which are pro-apoptotic, versus BCL2 protein, which is anti-apoptotic. So the BAX and BAC protein simply execute the cell towards the apoptosis, whereas the BCL2 is the anti-apoptotic thing, and that prevents the cell from the apoptosis. So basically, the BCL2 would be a bodyguard of the cell, and the BAX and BAC are executioners. So a high-level example from this would be that there is something called as P53, and it's a guardian, you can say, if the more correctly I would say, it would be a guardian of genome. And I cannot go into the detail of it, but P53 is something I will go into detail in next lecture when I'll be talking about the genetics. So P53 is actually guardian of genome, that's it. And this trigger apoptosis if the DNA repair fails. So it actually, this P53 somehow activates the BAX and BAC protein, right? Now, if I talk about another example I can give to you, so now you understand that how the BAX and BAC protein works. Now, by another example, I can explain to you that how BCL2 protein works. So, in a follicular lymphoma, BCL2 is overexpressed, so this apoptosis is blocked, allowing the cancer cell to survive, right? So if I can now you got the example that how the backs work and how the BCL2 work. If the BCL2 is hyperstabilized, if the BCL2 is working a lot, if it is overexpressed, then a cell cannot die, right? At the same time, what is the importance of backs and back? That backs and back protein are when the cell detect any sort of junk or any sort of damage, the cell simply activates the backs and back protein, and that leads to the activation of the back. That leads to the simply leads to apoptosis. But now let's suppose that if the cell is if the BCL2 is super stable, if this BCL2 is overexpressed, you cannot make the cell die, even if the cell is having the you can say even if the cell is having something wrong, even if the cell is cancerous, the cell cannot die because BCL2 is super stabilized. So this is how it leads to the survival of the cancer cells, and this leads to the neoplasia. I'll go into the new detail of neoplasia later on, but keep this in mind. Now, if I talk about the extrinsic pathway of the cell of the apoptosis, so extrinsic pathway is triggered by the signals from the outside the cell. So the classic triggers are Fas ligand pathway. The Fas ligand bind to the FAS receptor, Fas receptor, which is also called a CD95, and this leads to the triggers the cell death and the cell die. Actually, these Fas receptor and the TNF-alpha receptor are simply called as death receptor because once you activate these two type of receptor, cell eventually die. So a great example of this would be that negative T cell selection in the thymus, and the immune system selectively eliminates the self-reactive T cell through apoptosis to prevent autoimmunity. Now, if I talk about the high yield morphology and clues of the apoptosis and necrosis, so when you look under the microscope, I'll go into detail of this first. So when you look under the microscope, you can see the councilman bodies. For let's suppose you're seeing someone who has got viral hepatitis, right? Now, you can see if you do the biopsy of the patient, right, and you go into the lab and you put the biopsy tissue under the microscope, what you will see apoptotic hepatocytes in the viral hepatitis, and they appear acidophilic, and that is simply called as councilman bodies, right? Now, there are something also called as apoptotic bodies, and these small they are small. Actually, the apoptotic these councilman bodies are actually called as apoptotic body, and they are small intact cell fragments ready for phagocytosis, and that's it. So this is just an example of the councilman bodies and how they actually appear under the microscope. And remember, the councilman bodies are very important for your STAP exam, and USMLEs frequently ask about these things, right? I'm not going into the detail of this thing because I've already explained this to you while explaining this intrinsic pathway. So let me jump over to the apoptosis versus necrosis. Let me explain this to you because I'm not just satisfied. Because let's suppose the patient is getting viral hepatitis. By getting viral hepatitis, the virus somehow induces the apoptosis. Now, if you do biopsy of such patient and take the tissue under the microscope, you will see the apoptotic tissues. Now, these apoptotic tissues or body are simply called as councilman body if you are seeing this for hepatitis patient, right? And these apoptotic hepatocytes are small intact cell fragments that are ready for phagocytosis. All right. So now let's talk about the apoptosis and versus necrosis. So if I talk about the apoptosis, so apoptosis is of course a programmed suicide, right? It's a programmed cell that it's a suicide, whereas the necrosis, it is the uncontrolled cell that it's a murder, which I've already explained to you. Now, there are a few changes that you can appreciate under the microscope for the apoptosis, which is the shrinkage, which is also called as pycnosis, and for the and for in case of necrosis, you're gonna see swelling, which is the onchosis, because this word is related to some osmolar changes. Now, uh, the you can say that if I talk about the nucleus, so in the apoptosis there is fragmentation. You can see in the apoptosis everything is, you can say, it is packed, it is fragmented, it is into the pieces, right? Because again, apoptosis is a very cleaned, it is a very regulated, organized pathway. It is something like every family got two types of children: the one who is organized and the one who is very messy. So apoptosis is very organized. It packs up the stuff, whereas in necrosis it just simply degrades randomly. It spills out the stuff. It's you can say it make the floor messy. Thing make the stuff messy, and this is what necrosis is. Now, if I talk about the plasma membrane in apoptosis, the plasma membrane is intact. That's why there is no leakage of such stuff, and that's why there is no inflammation. But in necrosis, the plasma membrane is disrupted, and that's why there is inflammation. And of course, in the apoptosis, the cell contents are also intact, and there is no uh, sort of degradation of the cell contents, the cell organelles. But in case of necrosis, there is enzymatic degeneration or digestion of the contents, and there is, you can say that there is simply degradation or digestion of the cell content in case of necrosis. There is no inflammation in case of apoptosis, but there is frequent inflammation in case of necrosis. And just keep in mind, this is a very big principle for you to remember, that apoptosis is physiologic. It is physiologic. Mostly, it might be pathologic in case of, I have explained, in case of uh, viral hepatitis, councilman bodies are simply the pathologic thing, but it is often physiologic, like in embryogenesis. And you might have heard or studied the stuff in your pre-med that the webs of the finger during the embryo are degenerated or disregarded or whatever during the embryogenesis because of apoptosis, via the apoptosis. And the necrosis is always pathologic, it is not physiologic, it is mostly pathologic, right? Now, there are a few quick clinical proofs that I would say to you that apoptosis is physiologic. I told you, now we are good, yeah. So, okay. Now, we have seen the necrosis, which is messy inflammation, apoptosis, which is the programmed cell death. Now, we will shift our discussion towards the inflammation. Now, the necrosis is actually taking the lead on. We are done with apoptosis, and now we will continue something related to necrosis, which is the acute inflammation. So, uh, now acute inflammation is, you can say that there are a few cardinal signs and symptoms of the acute inflammation. So we have studied, right. If I give you a quick recap, so we have is learn how the cell adapt. We have learned how they get injured or die. The next step, right after the injury right after the death of the cell via the necrosis, is actually the inflammation. So this brings us to the brings us to the inflammation. The body is first time line of defense against the harmful stimuli. So there are a few cardinal signs of the inflammation. So let's start with the classic hallmarks. So remember the celsus from famous four signs, the plus stuff. I'll go into detail of that later. So the four cardinal signs of the inflammation are the rubor, which is the redness, right? And you can say rubor and color, right? So rubor and color are simply the redness, and that is caused by the vasodilation, and it is mediated by histamine, prostaglandin, and bradykinin. And simply imagine that the blood is rushing to the side like a highway traffic jam of immune cells, right? So rubor and color is simply a hallmark that is blood is drifting away, shifting away, shifting into the cell, drifting into drifting to the site of injury. And this blood is now loaded up with the lot of immune cells, lot of mediators, and lot of recovery organelles, or a lot of recovery cells, right? Now the next stage is the end of tumor. which is the endothelial, you can say, which is the swelling, simply swelling of the cell. It is caused by increased vascular permeability, and the endothelial cells actually contract here, and that leaks, and it causes the seepage or leakage of fluid, and that simply cause edema. And think of it as that the tissues are puffing up like a balloon. Now, the third thing is to lower the pain. Prostaglandin E2 and bradykinin mediators, they simply causes the pain signals to they simply causes pain, and this encourages the organism to protect the injured area, right? Now, the fourth thing is the functional ectasia or the functional lasia, which simply is a secondary sign of the inflammation, and it is usually due to pain and swallowing that is limiting the movement. So these are the four cardinal signs of the inflammation. Now, yeah, that's it. So now the key mediators of the inflammation are, first thing I've told you again, the vasodilation, which is mediated by the histamine, prostaglandin E2, bradykinin, nitrous oxide. The second thing is permeability, which is mediated by histamine, leukotriene, CD4, C4, D4, E4, leukotriene, C4, D4, and E4. And the third thing is pain, which is mediated by PGE2 and bradykinin. And the fourth thing is, which is the fever. I think that you should never ever forget that fever is triggered by IL-1 and IL-6 and TNF alpha. But IL-1 and IL-6 are frequently asked in exam. And what they actually simply causes that they increases the number of PGE2. It simply increases the synthesis of PGE2 inside the hypothalamus, and that leads to the fever. And last thing is the chemotaxis, which is the IL-8 caused by IL-8, C5a, LTB4, and kallikrein. And about this thing, you will just I'll tell you about this thing in a minute. So now let's talk about the rolling and migration, and then these are all the steps of the acute inflammation. Once we are good with it, you're good with everything for the physiology, right? Sorry, for the general pathology. So now, if I go into the detail of this, so first of all, keep in mind this is one of the highest yield process in the pathology. So I need you to pay attention to this. So leukocytes just don't jump into the tissue. They follow a stepwise, and they follow a highly coordinated process. So the step one is the rolling and migration. So there are few speed bumps inside in our vasculature. So what actually happens that neutrophil slows down along the vessel wall. Suppose the blood is flowing through the damaged tissue or the damaged area, and the patient is having rubor and color, right? Now the neutrophils slow down along the vessel wall, and this process is mediated by these speed bumps, which are actually the selectins on the endothelium, the E-selectin and the P-selectin, and they bind to sial. Lewis acts on the leukocytes. The P-selectin, E-selectin are on the endothelium, and sial Lewis X is present on the leukocyte, and these two binds and connects, and this binding mechanism slows down the neutrophil. This is what actually slows down the neutrophil. Now our next mechanism would be the step 2, which is the tight adhesion. So integrins, so what happens that neutrophils now they are firmly attached to the endothelium, and this process is mediated by the integrins, the CD11, 18, also known as LFA1, and they bind to the ICAM and VCAM1. And what actually simply happens that give me a minute, guys. So what actually happens in this case that the integrins, which are the CD11, CD18, and LFA1, they simply binds to the ICAM and VCAM on the endothelium. So integrins are on the leukocyte, and they bind to the and they bind to the ICAM and VCAM on the cellular adhesion molecule on the endothelium. The third thing is the diapedesis, and which is actually the transmigration, and the neutrophil squeezes between the endothelial cells, and this is mediated by the PCAM CD31, and it is simply like the neutrophils are sliding through a narrow doorway to get in the tissue. The fourth thing is migration, and in this thing the neutrophils move towards the site of injury following a chemical gradient, which is, and the attractors are the C5a, IL8, LTB4, and bacterial products. Keep this thing in mind: C5a, IL8, and CP4. And this is what I was talking about here, the chemotaxis, and that's it. So this is like a bloodhound following a scent trail directly to the infection or tissue damage. So if I give you a mental image, so it would be like there are signs signaled. So you can say that inflammation is a well organized. Think of inflammation as a well organized rescue operation that signal the alert. That signal the alert team, and vessels opens a gate, and neutrophils roll, stick, and slip, and follow the trail, and causes a targeted attack, and body removes the debris and fights the infection. And remember, acute inflammation is usually short-lived, resolved within the hours or to a few days. If it is not resolving in hours or few days, then it becomes chronic, and that is our next topic.